This morning I'd like to talk a little bit about the current radiological evaluation of the solitary pulmonary nodule, and this is indeed a common diagnostic problem in current radiologic practice because of the ever-increasing incidence of lung cancer in the population. And over the years, a number of radiographic procedures have been brought to bear in the diagnosis of solitary nodules, and I'd like to review specifically several of these. Plain radiography, of course, which I'm going to touch on. I think everyone here knows the characteristics of solitary nodules on X-rays and what they're supposed to look for. CT I'm going to cover in depth because I think CT is an important diagnostic procedure these days in diagnosing pulmonary nodules, and using biopsy to diagnose lung nodules has been beautifully covered by Dr. Westcott. Some other procedures that have been used or are being used, at least experimentally, conventional tomography, of course, has been used for years. I think in current practice it has been largely replaced by CT. Some digital techniques, dual energy digital techniques and digital analysis of regular radiographs have been used in some institutions for the diagnosis of solitary nodules and may be of some value. And MR has been evaluated, at least experimentally, but with its current state of development does not have a great deal to offer, I don't think. Now, in imaging a solitary nodule, there are really three questions we're trying to answer, or three things we're looking at. And this is regardless of what technique we're using to look at the solitary nodule. The first thing is, can we make a specific diagnosis? Can we look at the plain film or CT or whatever and diagnose the abnormality as something specific that does not need further evaluation? Well, that's the first thing we try to do, but if we can't do that, the next thing we try to do is decide whether it's benign or malignant without making a specific diagnosis. And if we can't do that, then we perhaps try to decide on the basis of our imaging studies what should be done, either needle biopsy or bronchoscopy, and we will call Dr. Westcott for that. Now, talking first about specific diagnoses, there are a number of causes of solitary nodules that can be reliably diagnosed and diagnosed with a very high degree of confidence on plain films or CT or whatever imaging study you happen to be using. And these include pulmonary AVM and pulmonary vein varix, mucus plugs, of course, which can have a characteristic appearance, so-called rounded atelectasis, loculated pleural effusions and pleural lesions can sometimes mimic lung nodules and can often be reliably diagnosed using CT or other imaging studies, fungus balls within cavities, and there are a few other lesions which can have characteristic radiographic findings that can lead to a specific diagnosis. And if we can do this, then that ends the diagnostic workup. Well, here, for example, is a patient who has some severe chronic lung disease representing idiopathic pulmonary fibrosis with honeycombing. There are a few larger cystic areas within this patient's lung. And over a period of 8 months, we can see an enlarging nodule in the upper portion of the right lung, and it seems to be related to a cystic area, or it seems to be a mass in a cavity. Certainly with this appearance, we would suggest fungus ball is a likely diagnosis. And in this patient, CT was obtained to confirm that diagnosis. We can clearly see, using the CT scan, the severe lung disease this patient has. Clearly, this is a mass within this cavitary lesion. It was diagnosed as an aspergilloma, and the patient was left alone. If we can't make such a specific diagnosis, the next thing we try to do is decide if the lung nodule we're looking at is benign or whether it's potentially malignant. And this can be accomplished in several ways. I'm not sure if there should be a slide there or not. The first thing we might want to do, apparently there isn't. The first thing we might want to do is look at the radiographic studies, either plain films or CT, and decide whether or not the nodule has a benign appearance. And there are some lesions that present on plain film having the appearance of a solitary nodule, which on further evaluation using conventional tomos or CT have a typical benign appearance. And this is a study that was reported in Radiology in 1987, reporting the appearance of various benign nodules on conventional tomography. And in this study, 38 of 38 nodules that were considered to be benign simply on the basis of an atypical appearance were in fact proven to be benign. And the appearances that led the authors of this study to diagnose these lesions as benign were that they actually were not nodular but linear. They were angular, perhaps an area of atelectasis or scarring, or instead of a single nodule, there were several nodules conglomerated together, which would generally suggest the presence of a granulomatous infection. Now this, for example, is a patient that we've seen just recently who was scheduled for a renal transplant but had a lung nodule detected on his pre-transplant radiograph. A conventional CT scan was done and a rather complex-looking nodule was visible within the left chest. And we obtained some thin sections or high-resolution scans through this nodule and resolved it to be made up of a number of small nodular foci. We are not seeing a single dominant nodule here, but a number of small nodules. This is a benign appearing lesion. This looks like a granulomatous infection because of the multiple small nodules. It was recommended that this patient have a needle biopsy for diagnosis, but in talking to the surgeon about this, we said, we'll do a biopsy, but we're not going to find something that looks malignant, and we're going to have to wait a number of weeks to see what culture is going to show, rather than taking the patient to thoracotomy immediately after a negative biopsy. And a biopsy of these lesions was performed, and nothing that was diagnostic was obtained from the aspirate itself, but over a period of weeks, an atypical Mycobacterium gordonii, no relation to Dr. Gamsu, was cultured from this lesion, and the patient was left alone. Now, there are a number of characteristics of solitary nodules that can lead us to believe that they are benign or malignant, and I think you're familiar with most of these. Large nodules are typically malignant, those over 3 centimeters, while benign nodules are generally smaller. But malignant nodules are usually irregular in shape, while benign nodules are round. Malignant lesions are usually spiculated, while benign lesions are usually smooth. Malignant lesions usually double in volume in a period of time ranging from 1 month to 1 year, while benign lesions double faster or slower. Malignant lesions often cavitate, while benign lesions usually don't. Now, these are all important diagnostic characteristics, but none of them are good enough to reliably use to diagnose a lesion as benign, and that indeed is what we're trying to do radiographically. But there are 3 things that we can really base a diagnosis on. One is patient's age. If the patient is less than 30 years old and does not have a known extrathoracic malignancy, a solitary nodule that you pick up on plain film is very, very, very likely going to be a benign lesion of some sort, and generally speaking, patients like that will be followed. Everyone knows this. If the lesion does not grow over 2 years, we call it benign and generally leave it alone. And if we see benign calcification on radiographic procedures, we consider the lesion to be benign for all practical purposes, even though an occasional tumor will sneak by, and generally follow the patient radiographically. And the typical benign patterns of calcification you're familiar with, so-called central calcification, diffuse calcification of the nodule, popcorn calcification, and so-called laminar calcification. And this is a diagram showing what each of these looks like. Diffuse calcification, obviously. Central calcification, very common with granulomas. So-called popcorn calcification is a subcategory of central calcification in which you see several foci of calcification centrally, not uncommon with hamartomas. And laminar or concentric calcification, which is relatively unusual. In a series of solitary nodules that showed calcification on plain tomos, we can see that diffuse calcification and central calcification are most typical, and laminated or concentric calcification is much less common. Now, how should we try to diagnose nodule calcification in trying to decide that the nodule is therefore benign? Well, certainly plain films can do it sometimes, conventional tomos can do it, but I think the most sensitive way to diagnose nodule calcification is using CT, and I think this has been established in a number of series, And I think the easiest way to understand this is to simply look at the results from these 3 studies in which conventional tomograms were indeterminate. That is, no calcification could be diagnosed using conventional tomos, but CT showed typical benign calcification. In Siegelman's article, 22%, Proto's article, 36%, a very recent article just published in Radiology, 29%. So about 30% of nodules that do not have calcification on conventional tomos show calcification on CT. And this is indeed why I think CT should or has replaced conventional tomos in this regard. Now, the use of CT to diagnose nodule calcification had its start back in 1980 in an article I suspect most of you are familiar with, published by Siegelman, in which Stan looked at a number of nodules, 91 nodules that were considered to be uncalcified on the basis of plain film studies, and using his scanner, which was an old AS&E model with 5mm collimation, he was able to find 20 patients, 20 out of 33 patients in this series with benign lesions, who had CT numbers that he considered to be diagnostic of calcification. And on his scanner, these CT numbers were greater than 164 Hounsfield units. So in other words, out of this 91 patients, he found 20 in whom CT was able to diagnose calcification, while conventional tomos were not. And this is a table from his original paper, and you can see that of the benign lesions, there were a number that overlapped the malignant group in CT numbers, that is, having low CT numbers. There was a group here of benign nodules that had CT numbers higher than those that would be suspected from an uncalcified lesion, and that he diagnosed benign on that basis. Now, one problem was, and it was a terrific problem, that no one could duplicate Siegelman's results. And this turned out to be because he had a very special, unique scanner that was able to do this, while the rest of us had scanners that were not. There were tremendous differences between individual scanners, between software programs that were being used to measure CT numbers with different scanners. And quite simply, there was tremendous variation in CT numbers that you would get from a nodule depending on how big it was, where it was in the thorax, how big the patient was, what the patient's chest wall looked like. Well, Elias Zerhouni at Johns Hopkins developed a CT nodule phantom, which is made by computerized medical reference systems. And this phantom, which you can see nicely displayed on your right, simulates various thoracic shapes and densities quite nicely. And you can see this part of the phantom looking like the lower portion of the thorax. Here's the upper portion of the thorax. You can add extra soft tissue. These parts here that look like bone are actually denser than the surrounding parts of the phantom. So this very carefully simulates the actual thorax. And plastic cylinders are included with this phantom that have different diameters and have a density that is equal to 164H on Siegelman's scanner. And these serve to simulate lung nodules. Now, this phantom was reported as valuable because it corrects for differences in measured CT numbers occurring because of differences in nodule size and location, differences in thoracic size and shape, and differences between scanners. Now, quite simply, how you use this phantom is that after you scan your patient's nodule using thin collimation, which is essential, you construct the phantom to simulate the thoracic shape and level, nodule size, and position. And here you can see the phantom all put together with a nice nodule in the right lung, the nodule measuring perhaps 2 or 3 centimeters in size. And following your patient scan, the phantom nodule is scanned using the same technique. Then you simply compare the density of the patient's nodule and the phantom nodule. And if the patient's nodule is denser than the phantom nodule, it contains calcium. Now, in this, or in studies using this phantom, it has been considered that if you see 10% of the pixels containing these high CT numbers, that is, quote, significant calcification. Well, here an example. A patient with breast carcinoma who presents with a solitary nodule on the left side in the upper portion of the thorax. The phantom here is assembled to closely simulate thickness of chest wall, the same portion of the thorax, the same size nodule in the same location, and the phantom is scanned. Next, what you can do is make the window level or the window very narrow, and then raise the level until the phantom nodule disappears. And you can see the last pixel in the phantom nodule there just about to disappear at this window level. And then look at the patient's nodule with that same window level. We can see here that there are still a larger number of pixels within the patient's nodule that are visible at this same window level. That would indicate that these nodules are denser than the phantom and therefore contain calcium. However, is this enough calcium to call this lesion benign? Well, this is a blown-up look at the patient's nodule, and this is a blown-up look at those dense pixels. These do not constitute 10% of the size of the nodule, and if you look at the position of these dense pixels, they are not central but sort of peripheral within the nodule. This cannot be called a benign lesion on that basis, despite the presence of some calcification, and this is a metastasis. Now, how accurate is this phantom, or does this phantom help a lot in the diagnosis of solitary nodules? Well, in a cooperative study that Zerhouni performed and reported in 1986, 384 nodules which were apparently uncalcified on plain films or conventional tomos were studied. 65 of the 66 nodules that were called calcified using the phantom and CT were indeed benign. One nodule snuck in there with, one malignant nodule snuck in with significant calcification, but 65 out of 66 were benign, and 176 out of 229 nodules that were called indeterminate because they did not contain recognizable calcium turned out to be malignant. Well, in this series, how important actually was the phantom in making the diagnosis of calcification? If we look at the 118 benign nodules that were in this series, 65 or 55% were calcified. If we look specifically at those 65 with calcification, in about half, the calcium itself was visible on the scans without using the phantom itself. That is, with thin collimation and simply looking at the scans, calcium was visible. So even if you don't use this phantom, if you use thin collimation and scan through the nodule, you will be able to pick up a significant number of calcified nodules that you won't be recognizing on conventional tomography. Here an example, a patient with a nodule within the posterior right lung. This is a scan with 1 centimeter collimation viewed with a mediastinal window setting. The nodule is invisible. Commonly, I think we have the conception that if a nodule is calcified, we will be able to see calcium with 1 centimeter collimation. That is not correct. This is a thin collimated scan, a 1.5 millimeter scan through this lesion. You can see it to be densely calcified. If we measure CT numbers from this, they are in the 300 to 400 range. As a rule, if you have a nodule with recognizable calcification, you will see numbers of about 3 to 400. In our experience, or as a rule, we call nodules calcified if we see numbers above 200. Numbers between 200 and 400 will not typically result in obvious calcification, though, in just looking at the scans. In some patients with borderline CT numbers, the phantom can indeed be quite helpful, and this is a patient who presents with a small nodule peripherally in the right lung. The phantom is again set up and scanned to look just like the patient. And these are numbers that have been recorded from the patient's nodule, and we can see some 85s and 87, 161, 206, 141, a number of numbers in that nodule above 100, not high enough for us to call calcified simply on the basis of the value itself. Again, we tend to use 200. But if we look at numbers recorded from the phantom nodule, they're all in the 30s. So this nodule is indeed denser than the phantom. Therefore, we can call it calcified, and indeed it has been followed and is unchanged. Siegelman has gone on to replicate his study in a larger number of patients, simply looking at measured CT numbers in patients with solitary nodules. He has now studied over 600 cases, In about 180, he called the nodules benign on the basis of CT numbers. They were all proven to be benign. So again, you can be very accurate in diagnosing benign lesions using CT and looking at CT numbers. Of 458 that were indeterminate, that is, did not contain definite calcification, a large percentage had lung cancer. Now, in addition to looking for calcification on thin collimated CT scans in patients with lung nodules, it's also important to look for fat, because you can make a rather specific diagnosis of hamartoma if you see that a lung nodule contains significant fat. And Stan also reported a series of patients with hamartoma diagnosed using CT, and he had 47 cases that he reported, and he called the lesion a hamartoma if it was less than 2.5 centimeters, was smooth, and contained either fat or calcification, or a combination of fat and calcification. And of these 47 hamartomas, 2 had diffuse calcification with high CT numbers, 28 contained fat, 10 also had calcification, and CT numbers that he considered diagnostic of fat were minus 140 to minus 120. Numbers less than 40 he did not consider to represent fat. Possibly necrosis or other things could be confusing with intermediate negative CT numbers. 17 were not diagnosed using CT. This is a patient we have seen recently, a patient who presented with a nodule in the upper portion of the right chest. Here a scan with 1 centimeter collimation, here a scan with 1.5 millimeter collimation. Again, this is the kind of scan we will need to use if we are looking at nodule density. Here, looking at this nodule again with thin collimation, we can see that the nodule is very low in density and looks actually like subcutaneous fat. If we measure CT numbers from this nodule, they are all in the minus 80s to 145, certainly in the range that we would consider to be diagnostic of fat. We do not have proof that this is a hamartoma. Hamartomas can present with an appearance of diffuse fat with no recognizable soft tissue within them. This was diagnosed as a benign lesion on CT and has been followed. Now, one problem certainly in the use of CT in diagnosing solitary nodules is the calcified carcinoma, and a significant percentage of carcinomas will contain recognizable calcification. How significant is this problem? Well, Siegelman, in his series, found that 13% of the nodules he looked at had 13% of the carcinomas he looked at had some areas of focal calcification. A few high pixels here, some high pixels there, but not enough calcium to call it benign. So you will be able to see focal calcification in here up to 13% of carcinomas. In Zerhouni's study, 7% of carcinomas had focal calcification on thin section CT. 1 was called benign. Proto, 1 of 96 cancers had recognizable calcification using CT. And going way back to 1957, a study of specimen radiographs in patients with lung cancer showed an incidence of 14% with flecks of calcification. Now, how do we avoid diagnosing these calcified carcinomas as being benign? Well, we have to rely on the pattern of calcification and the degree of calcification to make that differentiation. These are 1 centimeter collimated scans in a patient with a rather irregular-looking nodule in the upper portion of the right lung. On this scan, we see several areas of calcification. At a higher level, we see another large area of calcification. Unfortunately, neither of these is clearly central in location. This actually was on the edge of the nodule, and even though it appears central on the CT scan, it is not indeed central within the nodule. In the absence of definite central calcification, you better be wary about calling a nodule benign. Also, a nodule with this rather large, irregular shape, you better be wary about calling benign, because certainly carcinomas can have calcification like this, and this was an adenocarcinoma. These are radiographs in a patient who presented with an ill-defined right upper lobe nodule. Looking at this, we can see a little calcification on its edge. If we go back to a film 4 or 5 years earlier, we can clearly see a small granuloma in the right upper lobe that we are now seeing in that location. CT was performed in this patient. Here is the rather ill-defined nodule. On this scan, we can see a small eccentric focus of calcification. This is an adenocarcinoma that is engulfing this pre-existing granuloma. Again, we're seeing a small focus of calcification that is eccentric within the nodule, and the nodule is rather ill-defined and irregular, and I think you should be wary about calling a lesion like this benign on the basis of calcification. One other thing we have to concern ourselves with in using CT to try to diagnose a lesion as calcified and benign is size. And in Zerhouni's series and Siegelman's series, nodules that were larger than 2 centimeters in diameter or 2.5 centimeters in diameter were uncommonly benign lesions, and were uncommonly, even when they were benign, it was difficult using CT to call them benign. For example, here, nodules 2 to 3 centimeters in diameter, 40 proved to be malignant, 9 benign. Nodules greater than 3 centimeters, 35 malignant, only 1 benign. Under 2 centimeters, a much larger percentage of benign nodules. In Siegelman's series, nodules greater than 2.5 centimeters in diameter, 115 were malignant. Only a total of 16 were benign, and of those 16, only 7 could be called benign on the basis of CT criteria. Both these authors recommend that when you're using CT to try to diagnose nodule calcification, you use it only on nodules that are less than 2 or 2.5 centimeters in diameter to try to avoid the possibility of calcified carcinoma and calling a malignant nodule benign, because there are simply too few benign nodules in the larger nodule group to rely on. The shape of a nodule is also something you need to take in consideration when you're looking at CT. Again, Siegelman's series, he found that when a nodule was benign or benign by CT, they were typically sharp and smooth or moderately sharp and smooth, either 1 or 2, that is nice and smooth and round or a little bit lobulated. But when something was irregular or frankly spiculated, as we see here, they were typically a malignant lesion. Although there were benign lesions that fell into that category, whenever you see this appearance, the chances of you misdiagnosing a lesion as benign when it is malignant increase, and you should, I think, avoid trying to diagnose a lesion benign when you see an edge that is irregular or indeed spiculated. For example, this is a adenocarcinoma, typical spiculation. When you see a nodule like this, you should not diagnose it as benign, even if you see calcification. This is a plain radiograph, and this does not project very well, but there's a spiculated nodule in the right upper lobe. If you see something that's clearly spiculated on plain film, you might as well not even try to use CT, because you're not going to be able to call it benign because of its edge characteristics. Therefore, in performing CT nodule densitometry, there are several caveats that we need to consider carefully. First of all, a large nodule, one that's greater than 2 or 2.5 centimeters, generally should not be studied because of the high frequency of malignant lesions and the greater chance that you're going to call a calcified carcinoma benign in that group. Similarly, if the nodule is spiculated, don't try to use CT to diagnose calcification. If the nodule is bilobed or complex, that if it consists of two portions or 3 portions, or it's dumbbell-shaped, one part can be benign, the other part can be a carcinoma. You should stay away from those. And if you see a nodule with only a few areas of focal calcification, you should probably avoid diagnosing those as benign and rely on diagnosing nodules as benign if they contain a lot of calcification. I think if you are using CT to diagnose calcification using this sort of densitonomic technique, it's good to get a technique and stick with it and don't change it very much, because changing KVP settings, etc., can change CT numbers. We use a 9800 GE with 1.5 millimeter collimation, We use 140 kVp because it has a good linear response to calcium concentration and less artifact. We use the bone algorithm to reconstruct the images because of better resolution. And again, the features that we will use to diagnose a nodule as benign.